Okay, so first of all, I'd really like to thank Sarah and Monica for organising this. I think this is absolutely fantastic. I think it's really important for us that do work in this space to be able to present our results and talk to patient groups and move forward on what really matters and the important results, important work that we're doing. So I think a really big thank you to you. I think it's really important that you've done this, and hopefully we can do this more often. So I'm going to be talking about translational so the translational opportunities. It may seem like I haven't practiced this talk at all. That's not true. I'm just from Australia, so I'm quite jet lagged. So I'm from Western Sydney. I'll be talking not just about what I do, but I work in quite a large group, and you'll see that as we go. Now, I'm a very basic scientist, and that's where I came from. So originally I did a lot of basic research, but then in about 2018 or 2019, we decided to move to translating this work into the clinic. And the question is, how do we translate the research into the clinic? And the reason we got involved in this was because at the local hospital at Westmead, they had a child that had a GABA-A receptor variant that was difficult to treat. They didn't know what was going on, and talked to us about whether we wanted to be in the project, and we said we would. And the head of pediatric neurology, Russell Dale, gave me this advice that has stuck with us throughout the time we've been doing this work. And it's like, you might think that you know a lot about this, and that you've got something to say. But the most important thing you need to learn to do if your work is going to translate into the clinic is that you need to listen to the patients. So Monica, if you think I'm saying the wrong thing, just jump in and grab the microphone. You're in charge. But now that sounded a bit like, what are you talking about? I don't really understand what you mean by that. But as we went through, we've realised that is the best advice that we've received so far. So let's have a look at some of the patients. So these are some of the patients I've got from Invariance, where you tell a very lovely story. So we've got Pillar on the left and Gillian on the right with two different variants. And if we look at Pillar, she has seizures when she's 9 months old. They were initially diagnosed as febrile seizures, and then as she grows up, they start developing non-febrile tonic-clonic seizures. Currently, she has an absent crisis, and she also has some autistic features. And that's a familiar story for some of the parents. Gillian, on the other hand, has seizures also very early on, but at an even younger age, 3 months of age. She develops intellectual disability, again a common story for a lot of these patients. So she's non-verbal, has hypertonia, and her seizures are uncontrolled and change. There are different seizure types. So what we can say from this is that the patients all have a different story. Different things are happening to them. And it's our job to find out why. Why have they got a different story? Why are they not all the same? So we thought, well, hang on. If they've got lots of different experiences, we have to go out, and this goes to the natural history project that you were talking about before and how important it is. We had to go and find as many people with these GABA-A receptor variants as we could and look at their phenotypes and see what common themes emerge, and then start to try and understand if there's a scientific reason why these experiences are different and if that might lead to changes in translation. Whoops, I didn't finish the title there. Anyway, and this is the basic plan we have. So this is our large group. We have a precision medicine approach where the patient it's patient-centered, but the patient's in the top left-hand corner. We have three different, this is basically for a grant, but we have three different streams. So we identify the variants and we determine the functional effect. Then we identify drugs for the individual using in vitro or in vivo models, and we use in vivo models to determine the mechanisms. And Chris knows a lot more about that than I do. We just hand in the mice sort of thing. So how have we gone? Well, our clinical team in Denmark has gone through the published and novel variants of about 300 patients. We've got more than 300 patients on our records now. And so all the clinicians give the details to Ricky. She's critical in this project, and she stores all that in a database. What then happens is they send the variants to us in Sydney, and so there's myself and Philip and Vivian, and we go and measure the concentration response curves, and then we determine is there any correlation between these changes in the dose response curves and the phenotypes. And so what we find is that curing GABA-A variants is at least two different scientific problems. It's probably more, but at its heart there's two major scientific problems. And I think about them because I'm a child of the 90s and I watched a lot of Roadrunner cartoons and always cheered for the coyote. I think loss of function, there's not enough fuel. Gain of function, there's too much fuel. And we denote these, so we use wasn't going to go through the technical details, but we had a bit of a discussion about it. So we use concatenated constructs, and we use 2 electrode voltage clamps, electrophysiology in oocytes. We have standards, so we have wild type is run every day. We have 10, minimum of 10 for each variant, minimum of 2 days. We always run control variants, so population controls, to ensure we know where the control is. And with some of the genes, for instance, alpha 6, we can see that the control population is very wide, and the beta 3, it's the opposite, it's very narrow. In the red of the loss of function, so basically it just takes a lot more GABA to open the receptor, and the blue is, red is the loss of function, a lot more GABA to open the receptor, blue is gain of function, a lot less GABA to open the receptor. And then we compare the phenotypes, and this is like the classic case at the bottom right, where we can see it's meaningful. So if we plot just the age of onset of all the gain versus the loss, you can see there's a really clear segregation of clinical outcomes. And probably the reason that there's such variance on the right is because they're febrile seizures. So the environment, when you have that first infection, actually plays a role in when you start having the seizures. So if we look at loss of function and gain of function, we start seeing typical features common to these 2 patient groups. Febrile seizures versus focal seizures, that's a very clear differentiation. The age of onset, and this original data set was in beta 3, but we do see it repeated, and you'll see these papers come out in the next year or so. We see the age of onset is about 16 to 18 months in loss, 0 to 4 months in gain of function, more likely to have autism spectrum disorders in the loss of function. Gain of function, almost all of them have severe intellectual disability, almost all are nonverbal, and they have these, about 20% or so, depending on the subunit, have these movement disorders such as choreoathetosis, athetosis, or dystonia. The loss of function might have ataxia. So they're very different patient groups. So when we go back and look at what are the patients telling us, it actually said there for these two patients, that on the left, that's a typical loss of function presentation. That's actually within the range of what we see for a lot of these patients. On the right, it's a gain of function patient. So yes, they're individual, but they're actually within a group. And that's great, because now we know, and we're getting somewhere as to how we can treat these groups. So we've tested approximately 250 variants so far. So we have a large capacity because we have a semi-automated, I was going to go into the technical, but again, we talked about, so we have a semi-automated apparatus where we have 9 different rigs, and you set it up and all the fluid exchange is done robotically. And so that gives us a capacity to do high throughput, or at least high throughput enough for the amount of variants that there are in the world. We've been able to do this in about 3 years. And if some of you have seen the beta 3 paper that we published, and the goal is to give you an idea so that when the clinician first says you have a GABA-A receptor variant, you don't have to go in and have a consultation, then wait for the functional results to come back, and then have another consultation. We want that to be relatively quick and very accurate. So we have basically a guide. If you see these key features, then it's likely to be a loss of function. And if you see these other key features, it's likely to be a gain of function. Again, natural history, really critical for us being able to say that, and really has a clear translation. And when you go through those families, if you look at that graph, you'll start to be able to see, you'll be able to pick whether they have a loss or gain. So really nice. So the benefits of what we do is that we can more accurately give knowledge to families of how the disorder is likely to progress. As I said, again though, that depends on having very good relationships with the patients and families and having very good data. We can understand the consequences at the receptor level, and we can design prediction tools based on only the variant identity. Hopefully we have a paper in submission which will let you know that that's actually not science fiction. That's something that I think will happen in the near future. Another critical thing is, and this is why we listen to the patients, what is the most important part of the disorder to treat? It is not always seizures. We'll talk about that in a moment. One of the things that's very hard is that we evaluate treatment regimes on a like-for-like basis. So what I'm forever surprised at when, so I do the statistical analysis of the clinical data, what I'm forever surprised about is the apparent randomness of the drugs that these patients are getting. I think you're probably told it's a bit of a lottery, right? And it feels like that when we see the data. We actually don't get enough of any drug to make a proper statistical comparison of whether those drugs work or not, because so many different drugs are tried and at so many different time points. It's all over the shop. And so that's a really critical thing for us to get right. And as we said before, you want to define cohorts that are appropriate for clinical interventions. You don't want to throw out a good drug because you've used it on the wrong cohort of patients or just a couple of patients within your cohort. A classic example of this is vigabatrin, and this is where we started. So one of the patients we had severe catatonia when they were given vigabatrin, so they went unresponsive, they had to be taken off it straight away. But another patient totally treated them. So they, although they were a mild loss of function, they were seizure-free, and they were very happy with that treatment. So really striking differences between the responses that you get to drugs. And that's probably because vigabatrin increases GABAergic activity indirectly, so the loss of function works well. Gain of function, it exacerbates it, and you have the side effects. So, and here's what I was saying. Families tell us, clinicians on behalf of families, tell us that seizures are not the worst part of the disorder, and particularly for the severe cases, just some of the little things, like my child hasn't gone to sleep for several weeks. That's what they tell us. And that's like some of the immediate things that we need to do. And so some of these, again, it depends on the variant. About 20 to 30% of the gain of function cohort have these movement disorders, and they're profound once they get them. So the patients are non-ambulant, they come with painful uncontrolled muscle spasms, they require surgical options, and little things can often mean a lot. And why do they get them? We don't know. We can guess. We've got a pretty good idea of what they might be. We've got no idea why they get this disorder. Intellectual disability. The majority of patients have some form of intellectual disability. A substantial proportion are non-verbal. And one of the troubles with this is, as unfortunately we heard earlier today, the clock is ticking. This may require early intervention. This requires us probably to get in before those compensatory mechanisms take over. I think intellectual disability is very much in that basket. Again, at the more severe end we have feeding difficulties. So we see a small proportion of patients, they're unable to feed independently. That's a terrible sign. So these are the patients that have a very high risk of early mortality and not SUDEP, basically because they fail to thrive. And the loss of function, a substantial proportion of patients have autism spectrum disorders. So we have some families that tell us, for instance, that the seizures are under control, but they're pulling their hair, they're angry all the time. This is really, really difficult. And so, it's something that can't be ignored. And so it's broader than just seizures. And again, it comes back to, this is one of the good things with the family history. It frustrates me when I get lots of different drugs, but it also frustrates me that the only record I have of whether the drug works or not is if it reduces the amount of seizures. But that's not the whole point. That is not what we're trying to do. We're trying to increase the quality of life for the children, and that is not just seizures. So I feel strongly about that, sorry. So coming back to what we're trying to do. So I think it's very clear, or it's very clear to me, other people mightn't agree, but it's very clear to me that you have at least two different types of variants, loss and gain of function, and treating them is going to take different strategies. So you almost, when you have, when we have them all in the one foundation, that creates a bit of difficulty because at some point it has to, after the natural histories, at some point you have to invest in the two different diseases that you're trying to treat, and you have to make that decision, which is unfortunate. But it's highly unlikely you'll have a drug that, helps all of the loss of function or all of the gain. But it's impossible that you have one that helps both. So how are we going to do that? So again, I don't want to steal too much of Chris's thunder, but he is working with our beta-3 and delta gain of function variants. So as he said, these were very difficult to create. There was very high mortality. It was really hard to get a mouse in the Goldilocks zone. It wasn't that expensive because the Australian government actually subsidises making of variants using CRISPR. So it doesn't cost us, Oddly, it actually cost me more when it went from one animal house to another to put it behind the quarantine barrier than it did to make the mouse. So making them expense is not the problem. It's the time and the luck of the draw of getting, as Chris said, getting the mouse that you can work with. We have people that are starting to look at the stem cells. It is not my area of expertise. I'm not really sure how they're going to use that and the benefits of it. And so hopefully there's somebody in this room that can jump in on that. And also the repurposing, so assessing standard of care of different modulators. And in saying all that, and I know that was really negative, and sometimes it feels really negative. In fact, often it feels really negative, but we do have some successes. And so here's one that my colleague Vivian published very recently. And so this drug is banned in Australia, which is unfortunate. But vinpocetine, which is sort of a derivative of natural product, when she looked at it, so it was proposed that it altered GABA-A receptor activity, and she measured it, and you can see the modulation curve on the right. It increases GABAergic activity, and it does it at the variant receptor as well as the wild type receptor. They gave it to a patient with this variant, and it actually improved both the neuropsychiatric, in fact, neuropsychiatric where we saw more of an effect. It improved it dramatically, and the epileptic outcomes in the patient in that variant. So there are times where we don't need to go to a mouse model. We can use the in vitro when we're repurposing drugs and go straight into the patient. But in other cases, mouse models are going to be critical. I really think they're going to be critical with the gain of functions. Just got two examples here. I think Sarah's on one of them with the 4-phenylbutyrate. And I thought I had Chris's R43Q mouse, but obviously I don't. Anyway, never mind. So you can see that you can measure the spike and wave discharges, and you can measure the counts in wild type and mutant mice, and we can use that and we can apply different drugs to try and see if they're going to work in a mouse. We'll probably have to use different markers, different biomarkers in gain of function mice, but so long as you get a biomarker in that mouse that is relevant to the human condition, then these are useful. They're the best tools that you're going to have, I think. Inducible mouse models, we haven't made yet, but we are talking about inducible mouse models in development. Just an example there, and I thought Kieran's talk was very interesting about trying to find out which cell populations are the reason that we have these particular disorders, and we're looking at that particularly for movement disorders. Again, I'm going to leave this up to the discussion. Gene therapies for gain of function variants. If you had have said this to me probably 2 or 3 years ago, that ASOs were going to be a big thing, I'd have run away. I'd have politely declined. But I think it's very clear that I'm wrong about that, and that ASOs are showing a really, really strong potential, and it's absolutely imperative, I think, that somebody at least looks at this seriously. There are problems, of course, in the fact that you have loss and gain. If you give it too much, then do you turn your gain into loss, etc. But I think they're surmountable obstacles. The other thing I think is really important is, and this comes to the 4-phenylbutyrate, if you have a drug that works in SL6A1, so I know the SLC6A1 have a very active patient advocacy group. They're well ahead of where we are in the GABA-A receptors. If you have a drug that works with that, well, that should work for gain of function delta delta patients. You should be trialing it, and that's really important. So making sure that we're aware of what these other patient groups are doing that are not just GABA receptors but a little bit outside our field, and drugs that target SCN1A, SCN8A, they're being developed. And we need to look at those. KCC2, another example, I should put up. Thanks, Kieran, for that. And that's pretty much all I've got. And I think we should go into the discussion.